My name is Julie Madroni, and I'm an education trainee affiliate at T-CAIREM. We also have the second adjudicator today. I will be adjudicating alongside Kay Wu, who is also a T-CAIREM trainee affiliate. So today we'll be hearing from two trainees. Our first trainee is David Chen, who will be speaking about the development of an AI-driven system to augment informed consent in clinical trials. And followed by him, we will have Mahri Kadyrova, who will be speaking about a deep learning-based tongue segmentation and motor analysis in motor neuron disease using uncontrolled videos. Our first presenter, David Chen, is a first-year radiation oncology resident at the University of British Columbia. He completed his MD at the University of Toronto and BMSc at Western University. His research interests include cancer bioinformatics and applications of AI for clinical decision-making and patient care in oncology. Through his research, David aims to leverage big data and AI to generate evidence-based conclusions in medicine. Over to David to begin your presentation.
Thank you, Julie, for the introduction. Really appreciate it. It is a great pleasure to meet everyone here today, and thank you to the organizers for the opportunity to present at the T-CAIREM Trainee Rounds. My name is David. Like Julia's introduction, fourth-year medical student at U of T, now currently at UBC. I'll be presenting our work titled The Development of an AI-Driven System to Augment Informed Consent in Clinical Trials, supervised by Dr. Kieran Quinn at U of T and Sinai Health. So let's talk about informed consent. Informed consent is an ethical and regulatory requirement that precedes enrollment in all clinical trials. The process involves informing eligible participants about the benefits, the risks, and alternative options to support their voluntary decision to participate. In practice, the personalized education and the question answering procedure during informed consent discussions is often tasked to research staff, such as clinical trial coordinators and clinicians. You can imagine that this process can be very resource intensive for research staff due to the various informational needs for different participants, insufficient time, limited staffing availability and work hours, and human error. We've seen in the literature how these large language models, so popular ones such as ChatGPT, has shown great promise in simplifying informed consent forms, with the idea that they can translate very information-rich and dense text into something that's well-readable for a patient. However, the more challenging question is whether they can answer participant questions about specific trials in real time. So the main objective of this study was to design and validate an LLM system that can generate accurate responses to trial-specific questions as part of the informed consent process. So to do so, we hypothesized that an agentic system, which means involving multiple LLMs, could reliably generate accurate responses to participant queries that were grounded in reference trial documentation. Our workflow starts with a participant that poses a query about a specific trial that they want to enroll in. First, a coordinator LLM generates an initial response to this query. Then, a second moderator LLM rates the initial coordinator response using a Likert 1 to 5 scale for accuracy compared to the ground truth trial documentation and provides constructive feedback to improve accuracy. For responses with a Likert score less than 5, which we deemed inaccurate, the coordinator LLM is then prompted to revise its initial response to generate a final response that the participant then receives. The novelty of this approach is the application of this real-time self-auditing loop within our system, basically to check its own homework before outputting a response in a sensitive, informed consent discussion. So next, I want to talk about the actual design of these LLM systems. So we've seen previously how many of these initial pilot LLM studies were oftentimes just very simple, single prompt, single turn conversation interactions with these LLMs. Now, what we've been working on to design this more complex multi-step system is actually breaking it down into its constituent parts and essentially working on optimizing these different elements of our workflow. So focusing on both the context that we give the LLM, so what information to be provided, and the harness, what roles can it do and what can it not do. And so as we go through our workflow, we start with the participant posing a query. Then, if you recall from the workflow loop in the previous slide, the coordinator then retrieves relevant information from the trial documentation in order to draft its response. So it's looking into the database of trial protocols, standard operating procedures, and manuals, retrieving specific text chunks through a RAG-based approach. And then the coordinator synthesizes the relevant context into a specific response. Now, as I talked about, we have this second moderator LLM. And so this is supposed to be an independent agent that is taking a look at the coordinator's response, seeing is it right? Is it wrong? Are there any points that it can improve? And it's basing all of its decisions and the final accuracy rating in comparison to the ground truth trial documentation. And lastly, in our workflow loop, we had the coordinator revise inaccurate responses based on the moderator feedback. So it has context about its original response, the moderator's feedback to the original response, as well as the trial documentation. And then it's prompted to revise its own response again. Okay, so to test the accuracy of our system, we selected two prospective trials. Defend, a trial that evaluates antivirals to reduce cardiovascular complications from long COVID, and Can Silence, a trial evaluating prophylactic scopolamine to reduce death rattle in end-of-life patients. For each trial, we collated a set of trial documentation, such as the protocols, the grants, and the informed consent forms that comprises our ground truth knowledge base. Then, a team of 3 research coordinators co-designed a simulated set of 100 trial-specific queries that spans trial procedures, risks, benefits, rights, logistics, to mimic the expected types of questions asked by participants during real informed consent discussions. So our first objective was to identify which LLM that acts as the trial coordinator can generate the most accurate initial responses to participant queries. For each response to a patient query, a team of 3 human research coordinators independently rated the response's accuracy using a Likert 1 to 5 scale compared to the trial knowledge base. These scores are then averaged to generate one consensus accuracy rating. What we found was that across both trials, the GPT-5 thinking LLM generated the most accurate initial responses, followed by GPT-5 chats and GPT-4o. Importantly, we observed that LLM response accuracy varied between trials, where GPT-5 chat and thinking variants were equally top ranked in trial 1, but GPT-5 thinking was superior to the rest in trial 2. So this result suggests that for each unique trial, we should be conducting trial-specific testing of LLM response accuracy instead of deploying a one-size-fits-all solution where one LLM is applied for all trials. Our second objective was to evaluate whether our second moderator LLM could act as a reliable judge of the first coordinator LLM's response accuracy, essentially replacing the role of the human research coordinator team as a judge of response accuracy from the previous slide. So again, we compared, in this case, moderator LLM ratings of accuracy and whether they agreed with human trial coordinator ratings of accuracy for the same set of responses. So compared to humans as the gold standard, we observed that the GPT-5 chat LLM's ratings of accuracy were not significantly different and thus most similar to human research coordinator ratings of accuracy across both trials. Beyond statistical testing, we also observed moderate inter-rater reliability of LLM ratings of accuracy comparing to human ratings of accuracy for the same responses. Notably, we found that all LLMs demonstrated higher intra-rater reliability compared to humans across three independent replicates, meaning that LLMs tended to be more consistent than different humans when rating response accuracy. Our third objective was to test whether the coordinator LLM could revise its initial response based on the moderator LLM's feedback to improve the accuracy of its final response. Now, in this workflow, all coordinator LLM responses were rated for accuracy in triplicate by a moderator LLM. Any coordinator LLM response that received one or more accuracy ratings less than 5 among the three independent accuracy ratings from the moderator LLM was prompted for revision. Now, indeed, we found that our self-auditing loop significantly improved the accuracy of the draft coordinator LLM responses that were initially deemed inaccurate across both trials. In the confusion matrix below, where accuracy of the original response is shown on the y-axis and accuracy of the revised responses are shown on the x-axis, we observed that over 90% of initially inaccurate responses with a score less than 5 then improved to a perfect accuracy score of 5 post-revision in both trials. And so, taken together, our study demonstrates that this agentic multi-LLM system not only generates accurate responses to participant queries, but it can also self-evaluate its own response accuracy compared to ground truth knowledge base, and then revise the minority of inaccurate responses to reliably improve the overall accuracy of the system. Now, besides rating just the accuracy of coordinator LLM responses, a second role of our moderator LLM is to block these out-of-scope participant queries that were deemed unsafe. So, for instance, you can imagine that real-world trial participants might ask questions that are seeking individualized medical advice. They might have psychosocial concerns, or just be asking about non-medical content that's outside of the scope of this trial-informed consent discussion. So to address the safety concern, we queried a set of 50 out-of-scope questions across 3 replicates to our top-performing moderator LLM GPT-5 chat. We designed 3 conditions, including one where we had no guardrails to block queries as a reference control, a general guardrail that instructed the moderator to block any query that it deemed out of scope, and then an explicit guardrail that listed the specific categories of content, such as medical advice and non-medical content, that we think should be blocked. Across the 3 conditions, we observed that the lack of guardrails in the control condition allowed all out-of-scope queries as expected. The general guardrail blocked more than 90% of the out-of-scope queries, while the explicit guardrail, the one where we actually defined what we want the bot to respond with and what we don't want the bot to respond to, correctly blocked 100% of out-of-scope queries. So this analysis demonstrates that these LLMs require explicit instruction to define when they are allowed or prohibited to respond to specific participant query categories. This is very similar to, let's say, a competent trainee that needs explicit guidance from a mentor to make a marginal but meaningful improvement in their grades from just 90% all the way up to 100%. Okay, so in conclusion, our findings suggest that an agentic multi-LLM system can generate highly accurate responses to clinical trial questions when combining several approaches, including a retrieval system to ground LLM responses in reference trial documentation, a self-revision loop to audit and improve the accuracy of its own responses, and the design of a moderator LLM to also block these unsafe out-of-scope queries. We plan to evaluate whether the system can feasibly, safely, and accurately support real-time informed consent discussions compared to human research coordinators when deployed in a prospective clinical trial setting. So in conclusion, I'd like to thank the organizers of the T-CAIREM Trainee Rounds for the opportunity to present my work. In addition, I'd like to thank Dr. Kieran Quinn, Rebecca, and Idan from the core project team, and the broader study team for their contributions to this project, as well as the University of Toronto and Sinai Health for their generous support. Very interested in collaborations to validate and extend our tool to support informed consent discussions. So please don't hesitate to reach out to me over email as shown on screen and in the QR code. Thank you for listening. I'm happy to take any questions now.
Thank you so much, David. This is obviously very important work, and I think it's very important always to be thinking about how we can make AI tools that are patient-centered and patient-facing and that improve the patient experience. So excellent work, and thank you for sharing. We'll open it up to questions, first from the moderators, and then from the audience. So I'll start with one. Just a quick question specifically relating to the existing state of the field. I'd like to hear a bit from you about what exactly in this workflow is, novel or conceptualized by your team, and what components of like multi-LLM agents and RAG, are already well established, because a lot of this stuff is stuff that has been explored in other contexts and potentially even in this context. So set the stage for us a bit about what this field was like going into the project.
Yeah, that's a great question. So I'd say that some of the technical components of the system, so as mentioned, things like the retrieval augmented system to get relevant text chunks, of course, all these like new LLMs that keep emerging, we're all well established in the field, and we're repurposing many of these technologies within our system. In terms of applications of these technologies for informed consent, so what we've seen in the literature so far has mostly been more static deployments of these tools. So what I mean by that is between, let's say, a user and the system, most of the time there isn't a multi-turn interaction, alike to a human conversation, but really it's just you pose a question, you get a response, and there's no interaction. And so one of the main novelties of this entire work is to really create this multi-turn conversational agent so that instead of the patient, let's say in a clinical trial, talking to a human research coordinator, instead they're talking to this chatbot with a voice interface. So that they're able to hold a conversation and really ask all the questions that they need to. Now, from the technical side, what we conceptualized was that was novel was the self-auditing loop. So the idea was you had these two independent agents, each with their own vested interests. One was actually drafting the responses, the other was evaluating the drafter. And we showed that implementing this multi-step system can reliably improve accuracy of our entire tool. So I'd say those are the two main novelties, extending this to a multi-turn conversation, null agent, and then also our self-auditing loop.
Wonderful. Thank you so much. Kay, do you have any questions for David?
Thank you so much, David. That was a very interesting presentation, and I learned a lot. Yeah, I do have one question regarding the accuracy piece of your study. So, did you have a chance to look into the types of questions and responses that the LLMs were not performing as accurately on, and how that compared to, say, a human coordinator? Like, is there a meaningful difference between like an accuracy of 4 versus 5? I'm curious if you had any thoughts on like if you did look into that reasoning as to why like LLMs may not be performing as well on answering certain kinds of queries versus others.
Yeah, so great question. I think that that was one of our future directions to do a more thematic analysis of accurate versus inaccurate responses and really tease out why these LLMs are failing in a minority of cases. I think overall it's somewhat hard to say. I haven't seen any like consistent trends in our work so far to suggest that there's like one specific category that LLMs tend to fail in, like, oh, they're really bad at discussing like the benefits or the risks of a trial, let's say. I haven't really seen that type of trend. It's something that we want to look into and also, of course, work with some patient partners to see what they think about this tool before we move forward with a prospective deployment in a trial.
Okay, great, thank you.
Thank you so much, Kate. We have a bit of time for questions from the audience. So if anyone has questions, drop them in the chat and I can read them out loud, or feel free to unmute yourself or raise your hand as well. All right. If no further questions from the audience, I do have one more for David, time allowing. David, I was wondering if you could comment a little bit as well on, given that this is intended to be a patient-facing tool, if you've had any thoughts about how patients might respond to the tool, right? If a cancer patient looking at clinical trials is going to be receptive to speaking with an agent as opposed to with a clinician or a clinical trial coordinator, or any of those kind of more human aspects of the interaction, if your team has thought about any of that.
Yeah, we put a lot of thought into that. I think the work that we presented in this presentation today is mostly just to validate the pilot tool, but extending that into the clinical trial space and the real world is a whole separate challenge that we're still working on. With that in mind, we really thought about the usability of the tool. So you can imagine that the average user would be able to use a keyboard and they're able to like just type their questions, much like how any one of us would use something like ChatGPT. But for these clinical trial participants, that's a whole separate demographic from the average user. And so we had to think about how can we, let's say, like integrate like an easy to use voice function, for instance, or other ways to kind of like simplify the interface so that the user really just has to talk and they're able to get a response from the system. Now, that's one challenge, usability. The second challenge, which I think you're like really alluding to, is the acceptance of this type of tool compared to a real world human delivering this type of information. I think it's really hard to say what like trial participants will think at this time. I think we'll get a glimpse once we have some more interactions, focus groups with patient partners, and they'll give us an idea of like what patients might care about. And then a whole separate dimension to the evaluations and the prospective trial deployment will be things like feasibility, usability, acceptability, and we'll be measuring that directly from the patients and not just accuracy ratings as shown in this specific study. So something that we're looking forward to evaluating soon.
Okay. If there are no further questions in the chat, which there don't appear to be, then thank you so much, David. And we'll get started with our next presenter. Our second presenter, and feel free to share your screen, Mahri, at this time, is Mahri Kadyrova, who is a PhD researcher in the Department of Electrical and Computer Engineering under the supervision of Dr. Ervin Sedchik, collaborating with Dr. Yana Yunusova from the Department of Speech-Language Pathology. Her research applies machine learning to uncontrolled real-world video data to develop digital health assessment tools for remote monitoring of individuals with motor neuron disease. She's a recipient of the NSERC PGSD scholarship. Over to Mahri for your presentation. Take it away.
Sorry, I was muted. Thank you so much for your introduction. I'm very excited to be presenting for the T-CAIREM Trainee Rounds, and thank you so much for having me. So I'm a PhD student at the University of Toronto and at the Department of Electrical and Computer Engineering. I'm supervised by Dr. Sedich and Dr. Yana Yunusova from the Department of Speech-Language Pathology, and today I'll be presenting my recent work on deep learning-based tongue segmentation and motion analysis in motor neuron disease using remotely collected videos. So quickly, let's go over the outline for today. I'll begin with some clinical background on motor neuron disease and bulbar dysfunction. Then I'll introduce the objective of the study and overall research pipeline. After that, I plan to describe the methods, including experimental protocol, ground truth annotations, tongue segmentation model, and tongue motion feature extraction. And then finally, I'll present the results for the segmentation performance and clinical validation. And in the end, I plan to end with main conclusions and the next steps for the research. So let's go over the background real quick. Motor neuron diseases are a group of progressive neurological disorders that affect motor neurons. These are the nerve cells that control voluntary muscle activity, including walking, breathing, speaking, and swallowing. One clinically important area of impairment is bulbar function. Bulbar symptoms affect speech and swallowing, and they can lead to major consequences such as communication difficulties, choking, aspiration risk, and loss of speech. About 30% of people with motor neuron disease present with bulbar onset disease, meaning that speech and swallowing symptoms are among the first signs. Even among patients with spinal onset, many eventually develop progressive bulbar symptoms. Clinically, bulbar function is often assessed through a cranial nerve exam. During the tongue portion of the exam, patients may be asked to rest their tongue, protrude it, or move it side to side. And then clinicians evaluate characteristics such as tongue speed, range of motion, symmetry, atrophy, and fasciculations. However, these assessments are often subjective. They depend on clinician expertise and are limited to clinical visits. This creates a need for more objective and accessible ways to monitor bulbar motor function over time. Before getting into the technical details of my project, because there's going to be quite a few, I would like to briefly ground the work in a patient story. This timeline summarizes the journey of Tricia Baker's mother, who had bulbar onset ALS. ALS is the most common motor neuron disease. Tricia shares that her mother's first noticeable symptom was slurred speech in May of 2022. At that point, family doctors or primary care doctors were not concerned, and nobody thought there could be an underlying disease. And by February of 2023, Tricia noticed that her mother was difficult to understand. That is when her family doctor referred Tricia's mother for MRI and neurology assessment. In March 2023, neurologists noted tongue twitching, and in April, she underwent EMG testing and received a diagnosis of bulbar onset ALS. After that, her symptoms progressed quickly. By the summer, choking and falls became noticeable, and by November, she entered hospice. She passed away in December 2023. I wanted to include this timeline because it highlights why bulbar monitoring is so important. Symptoms involving speech, swallowing, and tongue movement can begin subtly, but they may progress rapidly. And in routine care, these changes are often assessed only during clinic visits, which may miss important changes over time. So let's come to the objective of the study is to develop a tool using remote video analysis pipeline to quantify tongue motor function in people with motor neuron disease. This pipeline has three main aims. First, we want to segment the tongue from remotely collected videos. What this means is we're trying to identify which pixels in each frame of the video belong to the tongue. Second, we want to measure the tongue movement by extracting quantitative motion features from lateral fast tongue movement videos. And third, we want to clinically validate these features by evaluating the association of these features with ALS-BDI-R scores, which provide a measure of bulbar function. I will cover that later. And so the project moves from having a video to getting tongue segmentation and then calculating motion features, which get clinically validated. So this slide summarizes the experimental protocol and the dataset. We collected 711 videos remotely from 133 participants across up to 2 visits. The median age of participants was approximately 65 years old. Around 60% of the cohort was male and 40% was female. In terms of onset type, about 70% had spinal onset and about 30% had bulbar onset. At each visit, participants completed 3 tongue tasks: tongue at rest, lateral normal movement, and lateral fast movement. Lateral fast task is especially important for motion analysis because it's designed to elicit rapid side-to-side tongue movement. And participants also completed clinical assessment using the ALS-BDIR, which we use later as the clinical reference score for validation. A key aspect of this dataset is that the videos were recorded in uncontrolled remote settings in patients' homes. That makes the problem more realistic, but it also makes it more challenging because lighting, camera position, video quality, and task performance varies greatly across participants. And this slide introduces the clinical reference measure used in the study, ALS-BDIR, or amyotrophic lateral sclerosis bulbar dysfunction index remote. This assessment was developed by our lab, by Dr. Yana Yunusova, and was also validated. And ALS-BDIR is a brief clinician-administered assessment designed for remote detection and monitoring of bulbar dysfunction. It includes 3 broad domains. The first is cranial nerve examination, which involves oral motor tasks and observation of structures such as jaw, lips, and tongue. The second is auditory perceptual evaluation, where clinicians rate speech and voice characteristics during structured tasks. And the third and final one is functional assessment, which captures how bulbar dysfunction affects everyday communication, speech, and swallowing. In our study, the ALS-BDIR was administered at each visit and used as the clinical benchmark. That means our tongue motion features are not interpreted in isolation. Instead, we test whether video-derived measures relate to a clinically meaningful score of bulbar dysfunction. And ALS-BDIR has a score of 140, where higher score means worse bulbar function, worse bulbar impairment. And so while computer vision pipeline gives us objective movement features, ALS-BDIR provides us with a clinical anchor for validating those features. Now let's get on with the methodology and ground truth annotations. To train and evaluate the segmentation model, we needed ground truth tongue masks. For this, 5 trained research assistants manually annotated the tongue in video frames. Up to approximately 100 frames were annotated per video, depending on the video length and quality. And overall, we had closer to 700,000 annotated images. These annotations provide the reference masks used during model training and evaluation, and the model learns by comparing its predicted tongue mask to manually outlined tongue region. We also used a participant level splitting for training, validation, and testing. This is very important because it prevents frames from the same participant from appearing in both training and testing sets, which reduces the risk of data leakage. We also performed annotation reliability for both inter-rater and intra-rater agreement. This was measured using intersection over union, which is quite a harsh but thorough metric for measuring overlap. Inter-rater agreement was 83.5% and intra-rater agreement was 83.8%, indicating that the manual annotations were reasonably consistent across raters and over time, but it still requires some optimization. So the next step is tongue segmentation. And the goal of segmentation is to classify each pixel in a frame as either tongue or background. We need actual tongue region because later motion features depend on the shape and position of the tongue over time. The pipeline begins with pre-processing. We crop the region of interest around the lower face and mouth region so that the model focuses on the area most relevant to tongue movement. We then train a convolutional neural network segmentation model. The model architecture is based on UNet with an efficient net encoder initialized using pre-trained ImageNet weights, but we tested various encoders and various decoders and concluded that all encoders and decoders did comparably well, and we chose just the best performing one for this presentation. Conceptually, encoder learns visual features from the image, such as edges, contrast, mouth structure, and tongue appearance. And then the decoder uses those features to reconstruct a pixel-level tongue mask. After prediction, we performed some post-processing to clean the mask, and we essentially applied largest connected component and filling holes techniques. And the output of this pipeline is a frame-wise tongue mask for every video frame, which becomes the foundation for motion analysis. Once the tongue is segmented in each frame, the next step is to convert those masks into quantitative motion features. First, we apply the trained segmentation model to every frame of a video. This gives us a continuous sequence of tongue masks over time. Second, we estimate the tongue centroid in each frame. The centroid represents approximate center of the segmented tongue region and is quite accurate. Third, we track the centroid position over time. This creates a trajectory that describes how the tongue moves throughout the video. From that trajectory, we compute motion features such as frequency, speed, acceleration, and directional speed of the tongue in lateral fast videos. Finally, these video-derived features are correlated with the clinical reference score ALS-BDIR to evaluate whether they reflect clinically meaningful variation in bulbar function. The idea here is that segmentation is not the final output. Segmentation enables motion analysis, and motion features are what we use to connect video pipeline to clinical assessment. And this slide shows qualitative examples of the segmentation model's performance. The input frames, which are on the very low on the left side, show the variability in remotely collected videos. These videos differ in lighting, camera angle, face position, mouth opening, skin tone, and appearance of the tongue and surrounding structures. The heat maps in the middle indicate regions that influence the model's prediction. These help us understand where model is focusing when generating the segmentation mask, and also making sure the model is focusing on the proper structures. The overlay images on the very right compare the model prediction with the ground truth annotation. Areas of strong overlap indicate that the model prediction is closely aligned with the manually annotated tongue mask, and they're shown in yellow. Overall, these examples show that the model can produce accurate tongue segmentation in remotely collected videos, even when recording conditions vary substantially and are quite unpredictable. However, remaining errors tend to occur near the tongue boundaries, especially around the edges of the tongue and the tongue root, where the visual boundary can be less distinct between the rest of the mouth and the tongue root. Although the model performs well in many cases, there are quite a few specific scenarios where segmentation becomes more difficult. One challenge is low contrast. When the tongue and lips are similar in color, the boundary between them becomes really hard to distinguish. And another challenge is mouth shadow. The dark interior of the mouth can confuse the model and cause errors in separating the tongue from surrounding oral cavity. Severe disease can also make segmentation harder. For example, limited mouth opening and reduced tongue protrusion, as well as saliva artifacts, such as shiny tongue surface, can all change the appearance of the tongue. And finally, the compensation is an important issue. Some patients may move their jaw along with the tongue, especially when the tongue movement is impaired. It's called jaw-tongue decoupling. This can create apparent motion that is not purely tongue movement because jaw cannot decouple from the tongue. These edge cases are important because they're not only technical failures, they also represent clinically meaningful situations, especially in people with more advanced bulbar impairment. And this motivates my future work to involve temporal modeling, where we can get the information across frames to improve robustness in difficult videos. This slide summarizes the quantitative segmentation performance of the selected model. In this case, it was UNet with EfficientNet B5, the highest performing model, but all the other encoder and decoder combinations also did really well. On the test set, the model achieved an IOU of approximately 87.7%. Intersection over union, or IOU, as mentioned before, measures overlap between predicted tongue mask and the ground truth mask. It's a quite harsh metric because it penalizes both false positives and false negatives, which are pixels wrongly labeled as tongue and pixels that were not labeled as tongue but were supposed to. The DICE score was approximately 93.1%, which also indicates strong agreement between prediction and ground truth. Accuracy was very high, but accuracy should be interpreted carefully in segmentation masks, since most of the pixels, like you saw in the tongue images, are background pixels rather than tongue, and a model can achieve high accuracy even if it doesn't perfectly segment the tongue. This is why IOU and DICE are more informative for this task. Overall, these results suggest that reliable tongue segmentation from remotely collected videos is feasible. So after extracting tongue motion features, we evaluated these features and whether they were associated with ALS-BDIR clinical scores. This step is important because good segmentation alone does not necessarily mean the features are clinically meaningful. We need to test whether the movement measures derived from video relate to bulbar function. And here we used Spearman correlation to assess associations between motion features and clinical score stratified by visit. The results show that tongue motion features have significant association with the clinical score, and this suggests that video-derived measures may capture meaningful variation in bulbar motor function. This means that patients with more impaired bulbar function tend to show changes in tongue motion patterns, such as reduced movement frequency, speed, or acceleration, depending on the feature. These findings support the potential of tongue motion features as remote biomarkers for monitoring bulbar dysfunction in motor neuron disease, but more work needs to be done before this becomes finalized remote biomarker. To conclude, this study shows that tongue segmentation and motion analysis are feasible in remotely collected videos of patients. First, we demonstrated that a deep learning segmentation model can segment the tongue with strong overlap performance, even in videos recorded outside of controlled laboratory settings. Second, we showed that motion features derived from these segmentation masks are clinically meaningful because they are associated with clinical reference score ALS-BDIR. Third, we identified important challenges: severe disease, low visual contrast, variable video quality, and jaw compensation remain difficult cases for both segmentation and motion analysis. And the next step will be to incorporate some temporal modeling so that the model can use information across frames rather than treating each frame independently. And we also want to perform analytical validation using gold standard equipment. And the main take-home message is that remotely collected patient videos can be transformed into objective measures of bulbar motor function. And I would like to acknowledge all the participants and the families who contributed to the study, as well as my supervisors, research assistants that provided all of the awesome ground truth data, collaborators involved in clinical assessment, model development, and thank you all for listening. And I'm open to any questions, either here or through email.
Thank you so much, Mahri. As you mentioned, ALS is such a rapidly progressive condition, and it's so important for clinicians to stay up to date with what is happening with their patients, especially as the disease progresses and people become, less mobile. It's remote tools like this are so important and have the potential to really change patient care. So excellent work. Again, we'll start with questions from the moderators. So I have one for you now. I know you mentioned in your talk that one of the places where the model tends to struggle is when there is advanced disease, there's limited mouth opening, things like that. I'm wondering if there was ever any consideration, or maybe as a future direction, of incorporating non-tongue features, such as just muscles of facial expression, potentially some throat segmentation, or like swallowing that happens during the test. Simply because, these could be extra dimensionality that may inform, if the model's like, oh, I can't see the tongue very well, but also this patient has a million other signs that they have really advanced motor neuron disease, then perhaps that is also actually another separate indicator of their bulbar function.
Thank you so much. This is actually an awesome question. And that touches upon my supervisor's work, Dr. Yana Yunusova's work, because her lab is not only looking into remotely collected videos and tongue motion, she also researches on speech analysis and facial movement, like lips and eyes, and chin, for example. The tongue was something that a lot of researchers tried to incorporate into remote assessment, but because of its internal position, hard to, record, it's it's still a big research work in progress. And but I would agree with what you mentioned that there are a lot of other muscles that get impacted, especially facial muscles or peripheral functions like swallowing and speech, which both are very hot research domains that my supervisor, Dr. Yana Yunusova, and my engineering supervisor, Dr. Irvin Sejdic, is researching on. Another case that I wanted to share was when we're developing these tools, it's very important to analytically validate them because we might be developing these computer vision, deep learning based tools, but what does it mean in, clinical domain using the gold standard equipment? And fortunately, we have a gold standard equipment like electromagnetic articulography, OptaTrack, X-ray beams that are able to validate, our tools. But when we think, for example, some other facial muscles like cheeks, we can't really measure as of now using the current gold standard techniques like electromagnetic articulography to measure like the motion of the cheeks and then to try and validate it based on deep learning techniques. So there's that limitation that I was looking into because I wanted to also explore into, how the cheeks affect the bulbar function and the lips. So that could be, that is coming in my hopefully next research work.
Excellent. Thank you so much. Okay, any questions?
Yeah, thank you so much, Mari. That's so interesting and yeah, amazing work that you've done. Yeah, I just wanted to ask a bit about like regarding how much variability there is in terms of using tongue function to predict like different, like you had described like as a spinal and bulbar onset types. Like, is there, I guess, like in terms of the value of this tool, like would it be mostly in like the early onset, like prediction of um, how quickly the disease is progressing? Is that like where you think the most use for this would be? And just to add on to that too, like you had talked about how the more severe cases were like the model didn't perform as well on, but perhaps like in those cases, it's not even as needed to have the model provide a score if we already know that the disease is already very severe. I guess I just wanted to hear your thoughts around those things.
Thank you so much for your question. You're actually thinking like my supervisor, Dr. Yani Nuswa, because we are talking about this a lot. We're talking about the intention and design behind this tool. Do we only want it to be able to assess the disease severity, but or also assess differentiate between healthy controls and patients that exhibit these symptoms, or do we also want to be able to spot any rapid decline in the bulbar function? These are all the questions that we're trying to assess, and eventually it all depends on sensitivity of these tools. Because as of now, as you saw in the presentation, very severe patients, we are not able to apply these tools reliably and with enough sensitivity to say that we are detecting clinically meaningful motion. And for that reason, we might be able to primarily start off with simpler cases and say, compare the healthy controls with patients that are exhibiting the bulbar function decline in the early stages, and then see how we can improve the iteration of the tools to apply to disease severity, as well as the rapid decline in the worsening severity cases. We did some preliminary testing, I remember, between um, various severity cases. And as of now, between mild and very severe cases, there seems to be statistically significant differentiation using these tongue motion features. But you'll know, being in the clinical space, even statistical significance may not necessarily indicate, very reliable clinical differentiation. So we're still looking into that, even though we did see statistical significance between mild severity and, very impaired severe disease severity. But we're still researching into that. And yes,
Amazing. Thank you.
of course.
Okay, take it away.
Thank you, Mahri, for the presentation. I was wondering, just to confirm, like the setup. So you have videos, but the segmentations were done frame by frame by hand.
That is correct. And let me actually open the methodology.
Sure.
We first started off with very, very simple design where we're treating, each frame independently. And this
Yeah.
is primarily for us to get placed in the current research domain of,
Mhm.
tongue segmentation and remote tongue image and video-based research. But I agree, the future needs to be incorporating that temporal component
Yeah.
and analyzing, the temporal associations and relationships.
Yeah, I have a few quick clarification questions based on that. One, how did you deal with when there's movement, if there's motion blur within these images? Two, the explainability part, if you go back to those slides, there were certain parts that were blue that were on the tongue specifically. Do you have any reasoning as to why that is? Three, results, there seems to be high variance in some of them. You see where exactly it was low versus high. And then finally, Spearman versus Pearson, is there a reason you used one over the other?
Okay, let me start with the first question before I
Yes.
forget it. Um, could you remind me what was the first
Yes.
question?
Motion blur.
Motion blur. Okay, so we face the motion blur both during the annotations as well as, model evaluation. Let me speak about the annotations because I think that directly connects to the model training. So it was really hard for us to establish like a standardized annotation protocol because in current research, there doesn't seem like a standardized annotation guidelines for tongue annotation specifically. And in most of the cases where, we weren't super sure about the tongue placement in very blurry, fast motion frames, we tried our best, but I think our best may not have been the true annotation because we did see the issue with the model evaluation where the model was really confused when it comes to, fast motion, blurry frames. And essentially what it does, it groups all the similar looking pixels of red and pink hues together, outputting that as tongue mask. And that is not super helpful. And that is where, touching on your question 3, where a lot of variation comes from because of these super blurry, high motion frames. We get a lot of variation. To tackle that issue, we have some hypothesis to try and incorporate again that temporal component, or maybe like even collecting the data at higher frequency. But I'm not super sure if collecting data at higher frequency will be feasible or even higher data quality because the blurriness does come, the original video is blurry as of itself. And the second question, I think you mentioned about Spearman, right?
Yeah, the blue versus red thing, and then
Oh,
yeah.
the heat maps.
Mhm.
Yes, what do they mean? I have several hypotheses as to what it means is from all the videos that I've seen, a lot of movement focused on below the upper lip part of the face. So the upper lip doesn't seem to move as much in all of the tasks that we have, and we see a lot of movement in the jaw and the lower lip, lower part of the cheeks, and especially patients that have severe, bulbar disease, there's a lot of decoupling issues. So, for example, the jaw moves with the tongue, and there's decoupling where, there's no decoupling essentially. And that's what I saw and kind of based these heat maps off of, that the upper lip and, the nasal area does not seem to be moving as much as the jaw and tongue region. And because the muscles of the tongue, also connected a lot to the jaw, we see a lot of that movement. And to speak more on the severe cases, what we observed was in severe patients, there's this overcompensation mechanism that happens where because the patients are aware that they're losing muscle and functionality in tongue, they're trying to overcompensate it by moving it more. So we see more rapid movement of the jaw, of the tongue, or at least an effort to move them really rapidly and fast to fulfill the task. But essentially, it doesn't really result in, true movement, but instead more like a jitter of the jaw, but the top lip stays static and unmoving. So that's why, to me, the blue region, which means that model did not really focus as much on that region, it indicates that, in most of the videos, especially we have um, older adults, the upper lip is not moving. Yeah. And any other unanswered questions that I have?
Sounds good. And was it one ground truth you had for each frame?
Yes, I do have a
Got it.
single annotation, but we did have, for example, for the reliability analysis, we did have 5 research assistants annotating, for example, the same set of videos across all 5 research assistants for inter-rater reliability, and then they performed the same set of videos in their own collection for inter-rater reliability.
Thank you so much. We are at time. So, Mahri, if you want to put up your email again, just in case anyone has further questions, you're welcome to contact her via email, as she mentioned. Other than that, thank you all so much for attending today. And thank you to both of our presenters for your wonderful work. Have a great afternoon, everyone.